Oh, you're taking a picture. Finally taking pictures. Somebody's taking.
Tried to get a nice catchy title. My friend Paula helped me with that.
What's the catchy title?
Watch your step before you wreck. It's medication reconciliation. So my name's Laura. For anyone that may or may not know me, I've been shadowing or working with Paula. I am in my master's program at Drexel, and I will be graduating in June. My master's is nursing education and in the faculty role. So we looked at quality data, and we saw that there is a need for medication reconciliation documentation increase. So I thought that I'd make this presentation today to go over documentation styles, and we have an example at the end, and also just a recap on medication reconciliation. So it starts in a three-step process. So we're gonna. It's not working. Technology. So the objectives of the course, we're going to define medication reconciliation. We're also going to describe the steps. We're going to explain how to overcome 3 barriers and how they impact an accurate medication reconciliation. We're going to analyze one, and then we're going to critique one. We're going to analyze how they impact errors, and then we're going to critique one. So, perception versus reality. I know this would be like the perfect scenario. Everyone's pill bottles are lined up nicely and neatly in their medicine cabinet. There might be only 1 or 2. Everything's from the same pharmacy. Nothing's expired. But really, it's okay. You may or may not have this situation at home, or you may be experiencing this if you're a home health nurse in the field. Many different medications come from different sources, as in different physicians' offices. Some may be expired. They might be just thrown together in different places, junk drawers. So the importance of safety and medications. So one of the top patient safety errors is medication errors. And the top. Hospitalized patients occur on average, 1 error a day. Home care patients are at risk 1 in 3. And Medicare patients and patients over the age of 65 are at greater risk because of their multiple comorbidities, their chronic illnesses. I believe in the elderly over the age of 65, they are one of the top causes of death is medication error. So here's some statistics. In the elderly, 1 in every 30 hospital admissions is due to a medication error. And 30% of discharged hospitalized patients in a whole have medication discrepancies. So that means 30% of the people that are going home from the hospital have a medication issue. Where does that bring us? What's the issue? Well, medication reconciliation has been acknowledged by the Joint Commission and CHAPS as a way to prevent these errors and to really look at the medications and reconcile them as preventable. So with the 30% of hospitalized patients, 24 to 33% of them are preventable. So there's 7 million preventable errors a year, and it costs $21 billion. That's huge. For me, that's huge. So what can we do to prevent these errors? So medication reconciliation. So medication reconciliation, we're going to go over, helps omit dosing errors, duplicates, and it's also very important in transitions of care. So transitions of care. So a transition of care is when you are leaving one healthcare setting to another. Also, a transition in healthcare is when you may be transitioning from one provider to the next. All right, medication reconciliation. So it's a 3-step process. You're going to verify, clarify, and then reconcile. So we're going to break these steps down and look at them one by one. So verify. You're going to get the list of active medications, whether it be from discharge summary or a primary care visit or an actual patient's list of medications. They should have the name, the dose, route, frequency, and the last time it was taken. In the home, it is, I feel like in the home and in the experience that you have the opportunity to actually look at the medications that the patients are taking and verify them. Let's see where the actual pill bottles are. Sometimes they go to the hospital and they may not report everything that they're taking. So in the home, you can actually visualize these medications. Are they being prescribed and are they being filled? Is the physician just taking a list of whatever's in the computer and just acknowledging that there's actual medications are being taken? So in the home, you have that advantage. So medications. So what are medications? Medications are not just prescriptions, but they're also over the counter. They're herbal remedies, they're vitamins, they're health supplements, they're respiratory therapies, nebulizers, and they're also creams and ointments. So with this, you want to make yourself aware so you can make patients aware. Not only are medications not just prescribed, but they're also in these other formats. So when a physician is doing an interview or someone's doing an interview with the client or the patient, what medications are you taking? Well, they might not understand that my fish oil that I'm taking every day on top of my Coumadin, you know, both of them have anticoagulation effects. Fish oil is a medication. So it's very important to ask the patient, ask the client, what medications are you taking? Did you know that this is a medication? So the first step, we were verifying. Now we're going to clarify. So we have the lists. Let's compare the lists. Now let's ask them, what are they taking and what is actually being prescribed? They might be taking half the dose. They might not be taking the dose. They may be not taking it because of different reasons. I don't want to take my Lasix today because I know I'm going to be out and about and I don't want to have to be making trips to the bathroom. So let's clarify that. Therapeutic duplications. So are there prescriptions for Coumadin and the patient's taking Warfarin, brand name and trade name? Drug-to-drug interactions, you want to check to see, okay, one example that I give is digoxin and quinolones. Their interaction is digitoxicity. So the quinolone increases the plasma of the digoxin, and then it can cause toxicity. So digoxin is an antiarrhythmic drug. So taking them together, it can increase toxicity levels of the digoxin. And let's look at inappropriate medications. So doing research, the Beers criteria was published by, go to the next slide, by the American Geriatric Society in 2012, and it was updated in 2015 to include the effects on the kidneys. So this list is a list of medications prescribed, or actually it's used as a reference guide to avoid in the elderly. One of the lists of medications may be Benadryl, because Benadryl effects in the elderly can cause dizziness and that can lead to falls, so they want to avoid that medication. Also, I like the Beers criteria because it breaks it down by body system. So you have the GI drugs listed, you have the antiarrhythmics, you have the anticholinergics. So it's a nice reference to see. And it also gives a rating scale of mild, moderate, and to severe. So after we clarified the medications, we looked at the list to verify, and we looked to clarify them to see what they're actually taking. So now we're going to reconcile. So this is the final step, and we're going to look at the medications, and now we're going to see what is the recommendation. Are there discrepancies? So this is a very important piece of this medication reconciliation. You want to make sure you're documenting these. So you want to be able to write legibly with the name, your name, who's documenting it, the dose, the route, the frequency, and the credentials of yourself, obviously. But you want to document this, but you also want to communicate with the physician. One of the tools that I give for communication is SBAR, and that's situation, background, assessment, and recommendation. So you found this discrepancy, and now you want to communicate with the physician what you found and what your recommendation is to resolve it. Often, sometimes in the home care setting, patient may be discharged home from the hospital and they leave with a list of medications. Well, the primary doctor may not be communicating with the hospital. So the nurse is in the home. She realizes the patient was just discharged. She goes over the medications and there's a discrepancy. What does she do? She calls the primary care physician. It's harder for her to call the hospital to get a hold of the physician that was treating the patient in the hospital. So she's going to call the primary care. The primary care physician may say, well, I haven't seen the patient. I don't know what's going on. I can't really tell you to start or stop this medication. Let's make a physician appointment. Which, as the nurse, you've communicated that. But however, want to document that. A rule of thumb, if it's not documented, it's not done. So if you don't document that, then no one else is going to see that you try to resolve this discrepancy. So who is responsible for doing a medication reconciliation? So in transition to care, usually it's done in admissions, transfers within the hospital, and at discharge. And in the home, it's done when they are admissions back to the home and transfers from physician appointments. So if they go to physician doctor's office for a complaint of backache or whatever you can imagine, they might prescribe a new medication. Well, when the client gets back to the home, you want to make sure that the new medication is matching up to what they're already taking and that the physician's office had a full list of everything that they were taking and that they were on the same page. Nurses and rehab skilled professionals are able to reconcile these medications. Medicare and Medicaid guidelines do say that during an initial visit, if it's just rehab services, that those therapists can document and do a medication reconciliation. So it's not just nurses. Obviously, physicians are doing it at transitions of care and when they're admitted to the hospital and in their physician's care office. Go ahead.
The problem arises when you have an elderly person that doesn't have anybody with medical experience or knowledge that's local to them, and they have to organize. I go to a pulmonologist, I go to an oncologist, I go to a GP, I go to all these different doctors who don't talk to one another. Therein lies the big problem.
Yes. And that brings us to our next activity. So I wanted to,
Yeah, really.
I wanted to ask you
If they bring the bag,
figure it out.
you know, if they bring the bag, right? And if they can find it in their house, there's some over here, there's some over there.
So barriers to accurate medication reconciliation. So let's brainstorm together to see what is in the way of doing an accurate medication reconciliation, and then maybe together we can come up with ideas to how to get around them and workarounds for tips for the future.
You can pay me later.
Okay.
We'll put up your barriers. I'll try and make them big enough.
It
for
just
everyone.
really upsets me because this is one of the biggest things that people wind up in the hospital. I took my furosemide and I also took my Lasix. What's the big deal?
That's why the elderly at risk.
keep myself on
Right.
my
Elderly
Yeah.
are at risk of
Yeah.
that.
I became hypotensive and then I fell.
And under multiple providers.
Yeah, and nobody who's in charge of the game.
So health literacy,
Yeah.
health background.
Nobody to help them. That scares the heck out of me.
All right, anything else you think we can think of? Go ahead.
Well, while therapists can do the medication reconciliation, I find they don't have the, sometimes, they don't have the passion or interest in doing it properly. It's ingrained in us as nurses.
Yes.
And not only that, but therapists, they view their role as sometimes pretty specific. And historically, it has not included medication reconciliation. So recently we have CPA, care plan appropriateness. We're sending more therapists out to do opens. But again, the best way I can say it is I find they're less passionate about performing the task properly, which then puts the onus on the clinical manager in the office to review it. And then we get into the whole issue of being busy, burdened with a lot of tasks, etc. So it's really not
Yeah, and do you know that they've even looked in every nook and cranny when they're in the house to try to find everything? So even if they give the list to the clinical manager, they may not have a complete
That's a good
list.
point. We actually never even trained the therapist to do opens. We just said, okay, now you're gonna do
Yeah,
this.
yeah.
When
I
this
mean,
all
do they even
started.
know where
And
to
they're in the
find all this
homes.
stuff?
They're the ones that can actually look.
If they had
they
a
can.
mind to do it, if they were really invested in it.
But in, for example, Maryland, the therapist fought tooth and nail. They felt it wasn't in their scope when really it is.
Right.
They just didn't want to do it. It's that simple.
So education,
Mm-hmm.
brainstorming and seeing how you guys, I kind of like gave you the answer, but I think education there. Do you think that there's anything else? We have a couple examples. I don't know if you want to just give me a couple more examples and then we'll go through the ways that we can overcome them.
But not,
Anyone?
not only with the education, but it has to be accountability.
Accountability.
I think something Deb said earlier, I think needs to go into the barrier, and that is the lack of a patient advocate.
Mhm.
So if a lot of families, members, or clients do not have anybody to help them,
Right,
I think that was important.
Patient advocate.
yeah.
Patient is actually capable.
Yeah, they still,
Right.
and as they get older and they get sicker,
Well, we think we're capable.
yeah, we do.
That's
do.
the problem.
Yeah.
You need an advocate.
I was just saying,
More
And
than
they,
can
they hide
find.
stuff and then they go and resurrect it. It's, oh, well, look what I found in this pocketbook.
I know.
Listen.
Listen,
On a state survey too.
Yeah.
I am guilty of a lot of that stuff. If you opened up my pocketbook now, you'd find all kinds of stuff. You never know when you need it.
Other barriers, can we think of any other barriers that may be crossed as a nurse or as a clinician to reconcile these medications?
Yeah, because a lot of our elderly are getting slightly demented, but they're still home.
When medication reconciliation first came out, I think California did a, what do you call that? They did a pilot, and they actually sent this nurse into the home with this one client, and this lady had multiple places of keeping her medication.
Sure.
So you have to ask about where else do you keep them, because she had them under her pillow. The ones that were under her pillow were the new ones that she got, and then in another place she had the ones that she usually takes. So it's multiple places, I think, in homes.
Yeah. But plus, some of them, they don't even count as meds.
Do they recognize it
They
as a med?
recognize
Because
it
it's
as
over the
medication.
counter.
Yeah,
Over the
yeah,
counter
yeah,
is not
yeah.
a med.
Yeah, the
My-
doctor didn't prescribe
And
this.
it's not a medication. Right. My husband put me on CoQ10 and
Right.
to help with my dementia.
So what Ann was saying, so you want to get all the medications together. So you want to obtain all the medications because there are multiple providers and there's multiple medications. I feel like you already said it. You want to get all the medications in one spot.
Just the communication too. I mean, I certainly know that
Yeah.
you can look at this list that I got from my discharge paperwork, and then I'm looking at my paperwork and I'm going, well, I don't have that. I have this dose, and then you reach out to them, and then if you don't get an answer, and in the home you've got something else entirely, you're like, well, so what would you like me to do? They don't. It's almost like, well, I've discharged them.
You and it's check
I'm
it off the
done.
list.
You're like, oh no, you're not done. And they're like, well, talk to the primary. And you're like, but this is what the primary tells me, but this is what's in the home.
Right.
So
There's
I
two
need an answer
differences.
from somebody. And they're like, well, the primary is going, I didn't order that. You're left in the
Well,
middle.
that's with the multiple providers.
Yeah, cool. Could you suggest anything? What do you think that we need to fix that?
Conference call.
What did you say?
A conference call.
Yeah. I got one. How about a breakdown in the process? Let's just say, it happened. Somebody is now discharged, but they went from ICU to PCU to med surge, and that medication reconciliation broke down along the way, and then they went home. So having accurate information is a barrier, I think.
Nobody holds them accountable. I don't
Well,
feel that
yeah.
anybody
We
holds.
got accountability up
Yeah,
there.
but
Yeah,
that's
a
all
big
along
one.
the pathway. It's a
Right.
long pathway.
So to recap, what do you think our best tools are to overcome these barriers? So we see that the patients have multiple providers. What kind of recommendations you think that we could do to overcome these barriers?
I think that we as one of the healthcare providers in the home can be more of the advocate for the patient client when then they are with that other, large scale provider, because, I was the only one then as a CM that with the caregiver saying, well, I remember being in that appointment and then telling me this, and I don't understand why it landed like this on the paper. And I could look at other discharge paperwork and it just kept staying the same. Nobody ever changed it in the system.
Yeah.
It just stayed as this systemic error and it just kept getting repeated. So
I feel like that's like accountability. Someone needs to
right.
take
So
responsibility.
yeah. To help them saying, let's, maybe I can help you and call them, write a letter, do something, right? And, do something with getting an order from this guy and saying, I got to get over there to them and somehow get it to change in that system. Because just making a phone call isn't doing anything.
Got to take the extra effort.
It is.
On behalf of your, I mean, you are the advocate for them.
And then the knowledge is only sitting, the problem is then the knowledge is only sitting with you.
Yeah.
Transfer off the case.
Right.
Then what happens? And it's a
I think-
lot of time.
We have a great list going, and I think we made some key points. So there needs to be increase in education, which was one of the reasons why I'm here today. So we can all educate each other. We want to obtain all the medications because we see that there's multiple polypharmacy meds going on. We need to start taking accountability and communication as to overcome these barriers. I said lists were incomplete. There may be language barriers, polypharmacy, patient reporting. They might not be reporting everything. Cooperation, knowledge deficit. They don't know what medications are. Health literacy. So I have a little video here for us and we can look at.
Who's going to be with the funny people?
Yes.
Mrs. Johnson, your blood pressure and heart rate are pretty low. How long have you been dizzy and lethargic?
I have been weak for about a month or so.
I see. Do you have any medical problems?
No, I am healthy as a horse.
Do you take any medications?
Oh yes, I take lots.
Ma'am, why do you take medications if you don't have any medical problems?
Well, my medications keep my medical problems away.
That's a good answer.
Of course they do. What medications do you take?
I take Liberide, Xanax, Maxalt, Pepsid, Topril, Indril, Tenormin, and Metoprolol.
Do you realize that you are taking 4 medications for high blood pressure? And 2 of them are the same medication, just with a different name.
Well, I have 4 doctors. Dr. Payne takes care of my blood sugar. Dr. Shakes takes care of my anxiety. Dr. Cuts takes care of my migraines. And Dr. Hertz takes care of my tummy. Why? What is the problem? Isn't more doctors better?
Ma'am, you are getting treatment from 4 different doctors for high blood pressure. You are taking 4 times the medication that you should.
Is that the problem?
Well, it could cause weakness, lethargy, and dizziness.
You mean just like I'm having?
Yes, exactly.
You are a genius. You have found my problem. What should I do?
You should tell all your doctors about the treatment you are getting from each of them.
You must be kidding. How could I do that? Their feelings would be hurt if they knew I was seeing another doctor. You are not so smart after all. Perhaps there is another paramedic I could talk to.
All right.
That's hilarious.
That is great.
But it's so true.
I know.
How
I
sad
want
is
the
that?
link.
Yes, I can share that for you. No
Yeah.
problem.
They should play that in every doctor's life.
Oh my God.
So what went wrong with the situation?
I thought it was perfect.
As far as medication reconciliation could have changed the situation, what do you think it would have done, and where are the hiccups in that situation?
She doesn't know what the medications are for.
Or, okay,
Right. And obviously all of her are not, there is no communication amongst her.
Yeah, but she's not
physicians.
telling them because she doesn't want to hurt their
No,
feelings.
she likes going to them.
Yeah, she
She
would
likes
tell
the
them that
attention.
so-and-so gave me this and so-and-so gave me that.
She's looking to rack up another paramedic. So she
She
likes
likes
that.
Yeah, this is,
so if you're in this situation as a nurse or as a provider, how would you approach this patient or this client and to make it a better situation as far as medication reconciliation?
you grab her by her shirt and go,
She needs to understand what those meds do.
no, she needs education.
Yeah, it really comes back to education. And as a role as a nurse, what role do they play?
Educators.
What else are we doing with the situation? What are we going to do with the medications? So we see that there's an issue, we see that there's a problem, but how are we going to fix it?
Have to go through the 3 steps: verify, clarify, and reconcile.
There you go. So the medication reconciliation, just like the Joint Commission has said, that we have these errors, what can we do to help decrease them? And they found that medication reconciliation is an effective way to decrease them as long as it's done accurately. So,
I have a question.
okay.
The statistics that you came up with early in your presentation, are they recent?
Yes, my sources.
So
are-
we have been doing medication reconciliation for how many years now? It's not getting any better. That's a shame.
It is. And also, I know there's been a lot of push to look at electronic medication reconciliation to see if that can decrease some of those errors.
And a lot of hospitals have implemented that.
Well, and even when they go to get their medications filled, one pharmacy doesn't know. There is no communication.
No,
We have
right.
all of these electronic systems,
Not
but they
talking to each
don't,
other.
right, they don't
to each
talk
other.
to each other.
Yeah.
And when
That's a
you're
problem.
elderly, you shop for your meds wherever it's cheapest
Right.
this month. So you
Yeah.
might get your Lasix here this month and you're gonna get it over there next month because it's cheaper over there.
Or you could be getting you could have already gotten a 3-month supply delivered from your online, your mail order pharmacy.
Yeah.
So maybe you're gonna keep using that one up before you even get this one filled and get another. I mean, there's so many other ways.
So many ways that it goes screwy Louie.
So as a nurse, want to make sure that you are reconcile this information. So if you come across these errors and you're in the home or you're in the hospital, you want to communicate that with the physician using the SBAR. The last step is to reconcile. So you want to say, hey, did you know that this person is taking X, Y, and Z? I just want to make sure you're aware. What can we do to make sure that this is the most safest thing for the patient? Client. I use client and patient interchangeably. So this is the fun part. If everyone has a mobile device or a cell phone, you can participate in this little through.
I don't know where it went. Oh, there it is.
So you're going to text the word Laura Clark 673.
What am I doing?
Texting Laura Clark to 673 to 22333.
Have to be caps like that
Do
too.
they have to be capped?
Not necessarily. No.
Okay. All right. We're also talking to some oldies but goodies that have to do technology.
All right. This is the address.
Now we do 22333.
Yeah.
3.
Yeah. So you're gonna. So the address is 22333, and the wordage is
message.
Laura Clark.
Yep.
Oh, the message is Laura Clark. I
Yes,
did it as
sorry, I
backwards.
should have clarified that.
Clark 6.
So now,
Wait, the address isn't Laura Clark?
Laura, no, you're gonna
That's
text
the
Laura Clark
message.
to 22333. Sorry, the message is Laura Clark.
Oh, and this is our first question, right?
boy, we're doing real good here.
Okay, we built in time for this.
Yes.
Okay. This is not working.
I'll come around and help you.
Wait, got it. Never mind. Got it.
Anybody else need any help?
And now we do your name. All right.
in errors, I guess.
Should give you, I think, a text back.
To create an account.
No.
Got one
Yep,
back.
got it.
It's got a text back, and then you can
Okay.
type A, B, C, or D. Then you respond back to that person with A, B, C, or D. That'll be your answer to the question. So medication reconciliation is the process for.
Oh, I have to put the answer in.
Yep, you just type
A,
that.
B, or C,
Yeah.
D.
You can see the answer.
Oh, the answer you have up there.
The bar graph, that's
You-
not the
you
answer. That's where the
Pick
group is
whichever letter you want to
responding.
pick.
Oh,
So someone has responded with 100%.
yeah.
They were 100% right or 100% wrong.
Doesn't tell you how many people answered.
Everybody vote.
Medication reconciliation, do we all dialed in? Are we still working on it?
Shouldn't put it in right away until we all put it in. That's cheating.
Oh, look at the screen.
Well, I have to look at the screen to find the answer.
That's part of your study.
Next
Yes,
Is to
question.
that's all
include
right.
older people in this?
No,
Uh-oh,
I mean,
look, somebody's already, okay.
okay, in the home care setting, a patient has a list of medications from their physician's office. What would be the next step the nurse would take and reconcile the medications?
I had it in there, but I didn't want to hit send.
How did you take your nursing board? You had to be quiet during that, you know?
Oh, my God.
Walking around.
I had the lady that was monitoring my thing, had to help me out
You
of
do
my
your board
chair.
electronic or paper?
Yep, electronic,
You did
yeah.
electronic?
I was the first electronic, and,
Do we all make our
You did electronic?
selections?
yeah.
Really?
Yeah. Well, I did nuclear medicine for 23 years.
So the answer
before it
is
came
B,
out.
verify which medications are listed and what the patient is currently taking.
She could be lying.
We're doing good. The
Uh-uh.
correct process of steps in performing medication reconciliation are which?
No letters.
So A, B, C, or D? The first one would be A. Second one.
I put that one in
You
first.
just said it a minute ago.
Did it? My heart already.
How we doing here? Everyone vote?
Gee.
So yes, the correct answer is A. You want to verify, clarify, and then reconcile. Care nurse recognizes her 86-year-old patient is complaining of being tired more frequently during the day. After reviewing the patient's list of medications, the nurse notes the patient recently started taking Benadryl for headaches.
Oh.
How would the Beers criteria be utilized in this situation?
You have to pay for this thing?
No, it's free.
I don't want to.
The version iPad. How we doing?
Done.
Yeah.
Yes.
You're so smart.
D is the correct answer. Beers criteria is a reference used for inappropriate medications used in the elderly. It is available online. Reconciling documentation errors and medication profile is not correct. Generic and trade name medications, we didn't give the other medication name of Benadryl. Identifying potential adverse drug reactions. So that may be an adverse drug reaction, or it's used for the wrong indications. It's used for headaches. but it's inappropriate in the elderly. Adverse
I had no idea.
drug-to-drug interactions. There was, I didn't mention it earlier, but there is a tool. CBS has a tracker, depending on the institution's policy, how you can look for adverse drug reactions. Don't want you to get confused with Beers criteria, but I mean, it is a tool and a reference because they may be taking the two medications like DIG and quinine, but like you might not memorize every different medication and how they interact with each other, but you can always check using different tools. Either in the hospital, they have different platforms available. Okay, last question. Reconciling a patient's medications, the home care nurse finds a new order for Coley's. The patient is currently taking Duplex. What would be the appropriate intervention for the nurse to take? I'll have to add that to my answer choices.
I like that. Shame it doesn't tell you how many people.
Yeah.
You probably have to pay
I
for that
probably,
one.
no,
I think the one
I set it
Bayada
up
uses
differently.
does, doesn't
Yeah.
it?
Yeah, it does.
If I remember.
You probably have to pay
Yeah.
for it to get it.
Yeah.
Or, I think I set this up as a survey. This time I could change it.
Fun to do these ways.
So the answer, yes, is to communicate with the prescribing physician using SBAR because hopefully you would have recognized that Coley's and Dopalox are the same thing and that they are duplicate medication. So that's part of why the medication reconciliation is so important because there's two different medications there. Well, maybe appear as two different medications, but they're really the same thing. So now I have this little example for you guys to break off into teams or groups, however you want to do it. There's 3 or 4, whatever you want to do. So there is a patient list, handwritten side, of their medications that they are taking at home. And they just left the hospital or the physician's office, and there's the discharge medication list from Dr. Garfield. So I want you to check the nurses. You're going to be the auditor or the mentor, however you want to look at it. You're going to look to see how the nurse did it in reconcile these medications. So you can look at her med profile there. She reconciled the medications. Are there any errors? Is everything accurate? And if there are errors, how can they be corrected? I'll give you some time, about 10 minutes or so. You have
Stop.
some time.
So this was this DC'd.
Changed.
Oh, wait, a minute.
So this is what she's taking. This is what the nurse wrote. This is what happened at the hospital.
That's correct.
This should be DC, right?
That, her handwritten note, that's her medication that she's taking. Yeah, that she tells you.
Before she went in the hospital.
That's correct.
All right. So.
Geez, I feel like I'm doing my. This is what I do. Cipro.
So what's new?
This is that. I don't know which sheet is. Forget what this sheet is.
This is what they came home.
Right?
This is what's here in the client's home.
Yes. Well, yeah.
Oh, no, is that what we're doing? Like,
Yes,
this is the
that was
pills that
their-
we're
that was-
seeing in the
yeah.
home, and this is what they should, this is what they came
Yep.
home with. So we have to-
All right. This is missing.
Zipper was really nice.
So she
It's in
probably
the
didn't
home. She didn't get it
get
yet.
it yet.
Or this is what the patient was taking prior to going to the doctor's office. Sorry. Yeah,
Okay,
prior
no,
to.
this is what we were reconciling. that
Yeah, yeah,
in the
yeah.
home. Okay.
Cipro,
She did have it. It's just a mistake. Chris Tour. She put this
Girl has problems.
Step before you wreck.
approaches here. So the dreaded. Remember that was like one of Barb's things. Tabs versus dose. Tabs v dose. Cinnabril.
All the classes, do we have to know that?
No, don't pay attention to the drug classes.
Yeah, that's not there at all.
It's the same thing.
Right, but it was on the other one.
Oops, she screwed that one up too. Does she have her glasses on?
This is just an error.
Yeah, we got it twice.
It's that. So.
So we can do.
Just do
duplicate.
It's been a while.
Yeah, that's right, you're
That's
probably.
what it is.
Joys of nursing. You see why parents don't want to do this? It's a lot of work.
She didn't do so good.
No,
How are you
she's not
making
the
out?
best.
No, no.
Nope, nope, no, and she didn't sign her credentials, so I don't know what she
No,
is.
you're absolutely right. And she initial. All these initials. I have to
Doesn't
circle.
even meet performance.
Here,
standards.
wait. Just put the line down.
There you
I
go.
saw
you
that,
go.
yeah.
QA's favorite.
Exactly.
Someone in advance. All right, so you can't really tell, but I tried to highlight them here. So here's the answer, Kate. So Thea Best wasn't Thea the best. So ciprofloxacin is a new medication because this patient does have a urinary tract infection and the patient wants them to be on this medication for 7 days. So yes, it's the first error. They did not write for 7 days. They want to make sure that they have the directions approved. Okay.
Got that right.
I think she did initial the first block, but nothing thereafter. Moving on down, amiodarone, that looked good, 200 milligrams daily by mouth for 3. So they want her to stop taking the Lasix.
What does that change mean?
So it means change, and they should have had a DCD
Yep, right.
because they're changing the medication. That was something that she was taking, but we're going to DC it. Right, moving, and then she didn't have her initial. So moving down, the duplicate medication was Pepcid and Formaldehyde. Right
I
there.
like mifemeritine because that's probably what the bottles are saying.
Yeah, so the patient thinks that she's taken one, but the physician wrote for another, so you can see how that can lead to an error. So as the role of a nurse or a clinician reconcile these medications, you want to identify those errors and bring it to someone's attention. So moving on down, we have lisinopril, 2.5 milligrams daily by mouth. Good. Aspirin, 81 milligrams daily. Crestor, 20 milligrams BID.
Should be Q days.
Yes. So actually, I've seen this too. They think they're supposed to take it 2 days, two times a day, and then they're only taking it once a day, so vice versa. That's important to make sure that everyone's on the same page. We talked about the Pepsid duplicate already, and the Wellbutrin, they rewrote the medication for 10 milligrams instead of 100, so the dose was wrong. So you can see not only is the name, is it the same name, but we want to make sure it's the correct dose, the correct frequency. Aricept was 5 milligrams at night for dementia, and she did not have on there metoprolol extended release 25 milligrams, and with the parameters. So that was another error. Down at the bottom, she did not say who she was. Was she a nurse? Was she? Is this the patient's mother that's filling out the chart? You know, who knows what. So you want to make sure that she documents that. And then the initials on the side we already went through. So 8 total. Just curious, did anyone get all 8? Or
Yes!
All 8? Yay!
We can do med-rec now.
All right.
Q&A
Just a
auditors.
refresher. Yeah. There you go.
If we didn't get them,
So
we shouldn't be in our
to
job.
wrap up, medication reconciliation is a 3-step process, and you can see from point A, you want to verify, you want to get the list. Then you want to clarify, you want to interview the patient and see what is actually being taken versus what is actually being prescribed. And in the home, I feel like there is an advantage of actually looking at, show me your medications, where are they? Go ahead.
No, I just thought of something. There are so many meds that people take PRN and they write and don't include it in this whole thing because I may have taken it like 6 months ago. That's not something I'd take now.
Yeah. Or they may not report it to the physician. Oh, I don't want to tell him that I'm on this medication. Or we saw in the video, like, oh, I don't want them to know that and this one to know that. But then again, you don't have all the medications, so you don't know what kind of therapeutic or non-therapeutic interactions are going to happen. Okay, so we talked about what it is, where do we do this? We do it in transitions of care, which can be anywhere from not just limited to the hospital, but we also saw in the home care setting when they're coming home from doctor's office or they're getting discharged from physician's office. And actually, it's a great tool to have a running list of these accurate medications. So when they go to another facility, they have everything there that's what's being taken and is it accurate? Are they taking half? And it should be a multidisciplinary approach. It's not just the nurse. It's not just the physician. It's everyone should be working and collaborating together. So we want to reduce the errors. We want to make sure our documentation and communication is clear. When you see an error, you're not just going to point the finger, but you want to communicate to the physician or the prescribing office or the healthcare team that, hey, there's something going on here. Did you know that this medication's so expensive and the patient's only taking it every other day? So, I mean, the physician needs to be made aware because then he can try and make adjustments. He or she can make an adjustment or be understanding of what's going on and what kind of dose is being taken. They're not just taking the purple pill because pills change their color, shape, size, and form. They look like candy. So that can be another issue. Look-alike medications, they think they're taking one, but they're actually taking another. So that's why it's important to be in the home. Show me these medications. Where are you getting them from? Names change. Names don't change, but maybe the color and consistency do. So that's pretty much it. Are there any other questions, comments, concerns that I could help with? Yes.
I did want to mention in our home care, home base documentation system, the clinicians are supposed to be reconciling
It's good to know.
therapists and nurses,
Yes.
which would be interesting to compare when we started that with whether it's improving or not. 'Cause I don't remember when they started that. But
Well, because they see it every day and they've become desensitized to it.
Becomes
Right.
rote.
Well,
Instead of-
there is literature out there saying that is a hiccup to the electronic Mars now. Everyone's pushing
Oh,
for,
yeah.
the Mars, and are the physicians actually reading it, or are they just checking off on it?
Mhm.
So that is a known problem.
Yeah.
Overload.
Yeah, because I mean, really, those numbers initially, they're very high. And this has been, oh my God, when did we start all this stuff? I was still in the hospital, so it was before 2009. So at least 10 years, and it's not getting better. Yeah,
I think the exercise you had was really good.
yeah.
Yeah, I like that.
Yeah.
And on your evaluation, please.
Yeah, there is an evaluation. You can just fill it out. It's anonymous.
Yeah.
I am going to be doing more work with this topic with Paula, so any type of evaluation would be greatly appreciated. Thank you.
Thank you. Good job.
Thank you. My references, always important. All right.
You're done.